Okay, and we are live. Welcome everyone to the first SJMC Grand Rounds for 2025. My name is Alan Tay, and I want to introduce my colleagues for today's webinar, which is the SJMC Cardiology Grand Round number 39. So the moderator for this session is Dr. Jayamala. Okay, and participants from the top, Dr. Puravi, and his son, Mr. Khuhan. Hi, Khuhan, and welcome. And Dr. Kanan at the bottom there. Okay, hi, Kanan. Yeah. So you have to bear with us a little bit because we might be a little rusty with not having a webinar for a couple of months, but we hope that there won't be too many glitches. All right. If you haven't already, please subscribe to our channel so that you'll be able to be notified of our upcoming webinars. Okay. Just a little housekeeping. Also on our Q&A, we'll be using Slido. So if you have the Slido app installed in your mobile phone, you can go to the app and enter the code 2980752, and it will take you to the events Q&A. Or you can just use your normal QR code scanner to take you to the Slido page for the event. Okay. There was a question already on our Slido, how to get CME points. Please be patient. At the end, there will be Q&A, and then we'll show you how to register to claim your points. All right. So I think without further ado, I'm going to show the slides from our presenters, and I'll ask Dr. Jayamala to take over. So over to you, Dr. Jayamala.
Hello, thank you very much, Dr. Alan. So as he mentioned, this is our grand round number 39, and we're going to talk about a very common symptom, giddiness. And the presenter will be Khuhan and Dr. Puravi. And over to you, both of you. You can start.
Okay, so I want to discuss my first case here, a 70-year-old female, known case of hypertension and dyslipidemia, history of coronary artery disease, underwent angioplasty in 2018. She's on Novas, atorvastatin, and Plavix. Her chief complaint was positional dizziness lasting for a few seconds for the past 2 months. She also has history of migraine, intermittent dizziness, with 2 attacks per year lasting for several hours. But the main complaint this time is positional dizziness lasting for seconds. Her previous dizziness was associated with phonophobia, photophobia, headaches, tinnitus, and neck stiffness, but no hearing loss.
Puravi, what is this? What do you mean by positional dizziness? And what is phonophobia? For me, that's all Greek.
Phonophobia is an intense and persistent fear of sound, which often leads to avoidance behavior and sometimes even causing significant distress to the patient. It normally occurs in patients with migraine, hyperacusis, or anxiety disorder, where normal environment sounds such as traffic noise, doors closing, or even loud speech can trigger these symptoms. Now, positional dizziness or vertigo that is triggered by change in head position, such as bending over to pick up something from the floor, or tying the shoelace, or when picking up something from the high shelf. This is to differentiate from spontaneous dizziness that can occur without any triggers. So in positional dizziness, the patient has a trigger, head movement.
Okay.
So initial presentation was this patient seen by a GP, diagnosed. The diagnosis was given to the patient is vertigo and treated with Stametil and Betaser. No improvement after 2 weeks, and symptoms got worse, especially when the patient looks up. And she had a history of fall. So subsequently, the patient the GP referred to the cardiologist.
Okay, why to a cardiologist? What are your thoughts if this patient came to you? And what in the history would have made you think that this is anything to do with the heart, Khuhan?
Okay. Thank you, Jaya. I mean, this patient has got very specific symptoms, which seems to have a very specific trigger for her dizziness. It seems to be position of the head. So I would immediately be biased that is an ENT problem. But having said that, she has got hypertension, she's on amlodipine. I would do some simple clinical examination to make sure that she doesn't have postural hypotension, which can occur in this age by itself and can be aggravated by antihypertensive. So we're not given much in terms of clinical signs, but I want to check her heart rate and I want to check her blood pressure both sitting and standing. And obviously, if the blood pressure drops the moment she stands, that already is an important etiology for her symptoms. And I suspect that given the way she presents, we're not going to see any alteration in blood pressure in this lady when she changes posture. The other thoughts that will occur to me will depend upon what I find during clinical examination, whether there are any heart murmurs to suggest aortic stenosis in someone like this, listen for a bruise in the neck to see whether there's any evidence for carotid artery stenosis, which I think will not be the case in her.
So this patient was subsequently referred to the cardiologist. She underwent ECG, Holter, and stress test. All were normal. Cardiac cause was ruled out.
Khuhan, are you quite happy? We're just doing this to say it's unlikely to be a cardiac.
I think if at all
there's a history of syncope or near syncope.
I mean, if at all this patient has been probably over-investigated. Probably the only appropriate investigation for this patient would be a Holter test. And if she had a 24-hour Holter and was normal, and we are still suspicious, we might want to extend the duration of the Holter monitoring because sometimes bradyarrhythmias, which is what we are mainly worried about as a cause of the symptoms, can be very intermittent. You may not have anything for a week and might suddenly appear. So depending upon your degree of suspicion, we might want to do a 3-day Holter or 7-day Holter, or if in some instances where the syncope results in injury in particular, we might even want to put a loop recorder, which can record patients up to 6 months.
But I guess for this patient, from the history that you obtained so far, I think you'll be quite happy.
Yes, I would think so.
Subsequently, the patient was referred to the neurologist. Neurological examination were normal. MRI and MRA brain were also done, was normal. Discharge with beta cell. However, the symptoms persisted.
Okay, maybe you may want to answer later. I mean, giddiness, when would you think an MRI is indicated?
Yeah, I will answer later.
Later, okay.
So, when I saw the patient, she had vertigo related to position change, no nausea or vomiting. Her vertigo was just lasting for few seconds, it's less than a minute. And since she had a history of fall, and especially with symptoms of, she also has history of symptoms of phonophobia, photophobia, osmophobia, kinesophobia, and history of motion sickness. All this shows that the patient has features of vestibular migraine. In vestibular migraine, they can have all these symptoms.
What are all these symptoms? Osmophobia, photophobia, kinesophobia.
Osmophobia is basically increased sensitivity towards smell, such as perfume. Suddenly, they get very anxious when they smell. They get feel very uncomfortable. Sometimes cigarette smoke, essential oil or incense product, causing irritation and avoidance towards this smell. And sometimes osmophobia also occurs in epilepsy. This can happen in epilepsy. Photophobia is abnormal sensitivity towards light, such as flickering or bright light, causing discomfort, pain, and visual disturbance. Kinesophobia is a fear of movement, and can cause also pain, which manifests in the form of restriction of movement and activity seen in patients with BPPV and vestibular migraine. So
Same
then
pain where?
they feel like
They feel fear.
fear. So ENT examinations were essentially normal. Audiological examination also are normal.
So, this is dizziness is very, very common lah. So, how do you realize that this is vertigo and not just normal giddy?
Okay, dizziness actually is defined of sensation of impaired spatial orientation without false sensation of movement. It's a constellation of symptoms within dizziness. It can be unsteadiness, lightheadedness, whereas vertigo is described of sensation of self-motion when there is no motion occurring. They feel the spinning sensation. Whereas in dizziness is impaired spatial disorientation. So they feel like rocking sensation, unsteadiness, lightheadedness. So it's a constellation of symptoms within the dizziness itself.
Let's see. I see a lot of patients, with this BPPV, and then you send them to ENT, and the ENT surgeon says, your ears are fine, the problem is not in your ears. Is there something that they should have done?
So your answer is yes, there's something is missing. To diagnose BPPV, an examination of the ears, hearing test, and MRI alone is not enough. Just like a cardiologist conducting a stress test. An ENT should perform a test similar to a stress test targeting on the vestibular system using provocative testing. These provocative testings, such as Dix-Hall pipe test, which assess the vertical canals. We have totally 3 pairs of canal. So Dix-Hall pipe test actually testing the posterior and anterior canal, and another test called macular Paganini, which we'll discuss. I'll show it to you on the video. Is to test the lateral canal. So you do a provocative maneuver, stress the canal, see the patient has got the symptoms on. If they have the symptoms and sign, this is confirmed of BPPV.
So basically, you said we have got 3 canals.
3 pairs of canal.
Must remember our anatomy to try to understand what you're saying.
Yes.
So your provocative test is to evaluate each canal in a particular plane.
Yes.
Right?
Yes.
In a particular plane.
Okay. So,
right. So after the patient saw the ENT, they were referred to the vestibular clinic where it was managed by an audiologist. So a positional video nystagmography examination was done where the Dix-Hall pipe, which is what Dr. Puri was mentioning earlier, to assess the vertical canals, as well as the macular Paganini maneuver were done. So just to show you, we'll just play the video down here. You can see that the patient's head is turned towards 45 degrees, towards the right, and the head is being extended over the bed by 30 degrees. Okay, so this is called a Dix-Hall pipe test, specifically a right Dix-Hall pipe test, which is used to test the right posterior and the left anterior semicircular canals. If you repeat this assessment in the facing towards the left side 45 degrees and have the head extended downwards, then you'll be assessing the left posterior as well as the right anterior semicircular canal. So if the patient has symptoms of vertigo, or you can observe nystagmus in the patient's eyes, you can diagnose them, to have either a posterior or anterior canal BPPV. And on the right, we have the macular Paganini maneuver. We just show you here quickly. So first, the patient is being put in a supine position, and symptoms of vertigo being assessed. And here we are examining if the patient has any nystagmus. After this, patient will be turned towards the right to be placed in the right lateral or a right recumbent position. And again, nystagmus is being observed. If there's any beating towards the ground, which we call as geotropic nystagmus, or beating away from the ground, which we call as apogeotropic nystagmus. So if patient has nystagmus in this macular Paganini maneuver, it's indicative of a lateral semicircular canal BPPV. So as Dr. Puri mentioned earlier, these provocative tests are extremely important to diagnosing whether or not patient has BPPV, and to identify which canal is being affected, we have to just perform the 2 maneuvers here and see in which position patients get the nystagmus. So here, patient is in the left lateral position. Okay. Again, observing whether or not there is geotropic or apogeotropic nystagmus, which is basically meaning beating towards the ground or beating away from the ground towards the sky. And the final position is patient is being put back into a supine position. So total of 5 positions altogether.
Can I just stop you? Huh?
Sure.
You said beating down or beating up?
Yes.
I mean, beating already, we all get excited. But what's the difference?
Okay.
Whether it's beating
All
up
right.
or down or lateral?
All right, sure. So nystagmus, okay, nystagmus actually has 2 phases. It has a fast phase as well as a slow phase. So when we say beating towards the ground, what we mean is the fast phase is beating, is going towards the ground basically. For example, let's say a patient is in a right lateral position, so having the right eye towards the ground. If the fast phase is towards the right side, which is towards the ground, that we call it as a geotropic nystagmus, or beating towards the ground. And then obviously, inversely, if it's beating away from the ground towards the left side, the fast phase towards the left side, that we call as apogeotropic, or beating away from the ground, or beating towards the sky, right? So
Geo means earth lah. So geotropic means towards the earth. Apo means to the sky.
apogeotropic.
In addition to this nystagmus, we were taught these maneuvers without knowing the names as young medical officers by our neurologists. They told us to do this, but in addition to nystagmus, I know nystagmus might be a bit difficult to pick up. But I think the important thing is the moment you do this, the patient has got a symptom, they will scream that, I feel giddy, this is what I have. They kind of clutch you, they feel like they're falling, right?
Yeah.
So there'll be a response by the patient.
Not all patients will respond.
Okay.
So some patients, I've got an orthopedic surgeon for 7 years having BPPV.
Okay.
And he did not even bother. So it
He did
depends
not
on.
know that he had been.
He knows there's something wrong, but he said, I'm okay. Because it's a benign condition. BPPV means benign paroxysmal positional vertigo. He is living with it. He said, I know if I sleep on this position, I will have this problem. So I don't sleep on it. For 7
So
years.
he may not complain,
Yeah.
but he experiences
Yeah,
that
yeah,
symptom,
yeah,
right?
yeah.
So this is what we'll tell the patient too, in addition to looking for nystagmus.
So, because very important, the eye movement is the most important, because all the canals are wired to the canals are wired to the eye. Depends on which muscle. So if it's a posterior canal, the superior oblique and inferior rectus. If it is a lateral canal, medial rectus and lateral rectus involved. So it's wired. So the eye movement is very, very important.
So depending on the canal stimulated, the subsequent eye movement, the subsequent eye will contract or relax, creating the nystagmus that we see in patients.
Can a patient just have nystagmus without feeling giddy or without feeling vertigo when you're doing this test?
Basically, no.
They must have symptoms,
Must have
right?
symptoms.
To diagnose BPV, yes, we must have symptoms. But there are also some instances where patients have nystagmus, but without any symptoms at all, where then we will look at central possibilities of vertigo.
Sometimes in vestibular migraine, they can have a positional nystagmus, but no symptom.
Vestibular migraine means they got headache lah. Migraine means got headache.
No. So this is a new term. According to Barani classification, European classification, there is a classification for vestibular migraine. They can have 4 symptoms. Not necessarily they must have headaches at all, but the diagnosis is called vestibular migraine without headache. They can have headache, they can have dizziness, they can have neck stiffness, they can present with tinnitus, and with all others, photophobia, phonophobia, motion sickness.
Right? Right. So just moving on. These are findings that we found from the positional video nystagmography. On the macular Paganini maneuver, there's no nystagmus, and patients asymptomatic. They don't complain of any symptoms of vertigo. Same with the left dick sulpite as well. And on the right dick sulpite, okay, this is what we observe in the positional video nystagmography. So positional video nystagmography, what we do, we will fit a pair of goggles, right, which has infrared cameras to observe the patient's eye in the dark. So we bring a cover on. So that allows the pupils to dilate. When we put the patient in the provocative position, the patient will depict the nystagmus that I will play here shortly. Okay, so you can just observe. So this is what I was mentioning earlier. There is a fast phase and a slow phase, which creates this thing that we see as nystagmus. So in this video, maybe it might not be so clear to you, but the patient is having a right portional upbeating nystagmus. Okay, and it is easier to be seen if you look at the graph. So the thing with video nystagmography is that you get a video of the nystagmus, as well as the nystagmus will be presented in a graphical format, so it's easier for us to observe. So if you can see here on the left graph, it shows as the up beating. And on the right graph, you can see that it's also a right beating. So that allows you to definitively tell that this patient has a case of right torsional up beating nystagmus, and it's also symptomatic, right? And with this allows us to make the diagnosis that patient has benign paroxysmal positional vertigo. But BPPV alone is not enough of a diagnosis for us to treat the patient. We need to identify exactly which canal has been affected. And in this case, based on the orientation of the nystagmus, we can tell that the patient's right posterior canal has been affected. Shortly, I'll share with you how we diagnose. So the management for this case is we perform a right modified Epley maneuver, which is a type of canalid repositioning maneuver or CRM. And the maneuver is repeated 3 times in the morning and at night for 5 days. Okay, I just show you how the video, the maneuver is done in this video. So patient has the head turned towards the right by 45 degrees and head is extended over the bed by 30 degrees. This is the first step of the disc pipe that we saw earlier, the right disc pipe. And stop there for 1 minute. And then you make the patient turn the body towards the left side and to face towards the ground. Right? And again in this position for 1 more minute. And after this, what we do is we get the patient to tuck the chin to the chest. Okay? And after that, we bring the patient back to a sitting position. And to make this maneuver even more effective, we actually request the patient, once they're done with the 1 minute, they stand up and they will actually jump on the spot with support, obviously, to allow for the jump to provide enough momentum for the crystal or the orthoponia to fall from the top of the semicircular canal back into the utricle. So this is a modification that we have made that has shown significant improvement in patients when we are treating them for this type of BPPV. Right? So just continuing on, after we've given the patient the management, the patient returned back to the clinic on the 6th day for a follow-up, and we actually did a reassessment of the positional video nystagmography, and we found that patient was asymptomatic this time, with no nystagmus, not just the right disc sulfide, which we found in the initial presentation, but in all the provocative tests. So in the right, left as disc sulfide, as well as in the macular Paganini maneuver, and patient was then subsequently discharged from the vestibular clinic.
So I guess if I get somebody like this, I pick up the thing, just send.
Yes.
So in ANT, not only we do the stress test, now we have similar like ECG, VNG. There's a graph from, where is that. So you can exactly identify. Sometimes what happens is that by looking at the eye, patient may feel dizzy, they scream, they close their eyes, so you miss the.
Yes.
So it only lasts for a few
Exactly.
seconds.
Yeah.
So if you don't capture, you don't know which canal is in. Sometimes when you do a disc sulfide test, which is for the posterior and anterior canal, but the eye can beat on the geotropic. We don't know. It can happen. Sometimes you do. So you have to do specific tests for the lateral canal. So say example, I do a disc sulfide on my, which I say I have a right posterior canal BPP. So I do a disc sulfide like that. So the fluid, if the particle is not in the posterior canal, but it is in the lateral canal, when I do that, the particles, the crystals can also move in the lateral canal. So even I do start with a disc sulfide test, but the movement, the particle is in the lateral canal. So the patient will feel dizzy. So the patient will scream. But if the patient closes the eyes, you think it's the posterior canal is the problem. But actually the patient had in the lateral canal. So you have to complete all the tests. Just cannot say one canal you test, patient have symptoms, then you say, oh, the problem is there. You have to complete all the stress tests on the semicircular canal.
I've got a very basic question.
Yeah.
You keep talking about particle.
Yeah.
Can you explain to us this thing about particle in the semicircular canal?
Okay, I have later I can explain. Okay, so basically, what is that? These particles are calcium carbonate. Calcium carbonate is found in our utricles. So, for our balance system in the inner ear, we have 5 senses. 3 semicircular canal to check all the angular movement. Utricle to tell you whether you're going forward or backwards. And saccule tells you whether you're going up or down. with all this information goes to the brain, gives you a 3D information of your condition. Okay. So what happens in BPPV? Calcium carbonate from the utricle get dislodged out and enters into the semicircular. It's a foreign body in the semicircular. So when the crystals out from the utricles enters into the semicircular, that's where they have BPPV.
That answers your question.
Okay. So basically, BPPV stands for benign paroxysmal positional vertigo. Most common cause of triggered positional vertigo in patients above 60, 30% will have at least BPPV. And sometimes patient can have two diagnoses. They can have vestibular migraine plus BPPV. Because patients with vestibular migraine are more prone to get BPPV. It's an inner ear problem. So, or patient with Meniere's disease. So any inner ear pathology these are the patients who are more prone to get BPPV.
Can I interject? Why does the particle get dislodged? It's just aging process?
Yes. So it could be aging process due to trauma, due to infection. Say after vestibular neuritis, patient can develop a BPPV. Can be due to Meniere's disease. It's basically endolymphatic eye drops. High pressure in the endolymphatics causing particles can get dislodged out. Okay. Sometimes due to trauma, injury. This more common in younger age because the crystals are very adherent to the matrix of the utricle. So in trauma, these particles can dislodge from the utricle and enter the semicircular canal. But the problem in trauma, they will have multi-canal. So in trauma, sometimes you have two canal. Generally, it's only one canal.
What about swimming?
Swimming, no. Swimming can get external ear infection and stuff like that. But no, don't get will cause vertigo. And it's more common in women than men because of their calcium metabolism. Okay, and basically, as I mentioned earlier, it's calcium carbonate from the utricle that dislodged out. In trauma, can be multi-canal. So symptoms of BPPV is basically episodic vertigo triggered by head movement, like picking up an object from the ground or on top of the shelf, rolling over in bed, getting up from bed, and episodes of vertigo normally last less than a minute. Okay.
So if anything lasts more than a minute, it's unlikely. Is that correct?
Unless more than a minute is more than 10 minutes or 3 minutes. So more than a minute can be, so if couple of minutes can still be BPPV. It is cupulolithiasis can present like that. Okay, so I will show you the pathophysiology of BPPV. It's basically, you can see the video. You can see the crystals moving out from the utricle now entering the posterior semicircular canal. So the patient is now standing up. Now when the patient lies down, you can see the crystals is moving. So this will cause the cupula in the semicircular to get activated, and action potential from there will cause the vestibular nerve goes to the medial vestibular nucleus. From there, it connects to the eye. You can see the vertigo. You can see. So this is what the patient see. When they have nystagmus, they feel the whole world is moving, and they feel that when they have this, they have some autonomic symptoms where they have nausea, vomiting, and
this must be a very severe case.
No, this is how
they feel.
Normally, another thing is, in lateral canal, normally they present with vomiting. Posterior canal, not so. But in the lateral canal, because the movement of the particle is basically amphilopetal. That means it's a stimulating movement. So this is very common in the posterior and the lateral canal BPPV. So here you can see sometimes patient drinking mineral water because you're looking up can trigger BPPV, or patient looking down pick up something, or in yoga sometimes I see patient I do certain yoga position, they get intermittent dizziness, and in the patient on the coming up on the ladder, this is no more benign really. We call it BPPV. Just imagine what happens when she has an attack of BPPV. So the types of BPPV can be either, most commonest is posterior canal, 80% of them, lateral canal about 17%, anterior canal roughly about 3%. Bilateral involvement is very rare, mostly post-traumatic.
Yeah, what is, you mentioned vestibular neuritis and then BPV, what is the difference?
Basically, BPPV and vestibular neuritis primarily differs in the term of triggers, recurrence and timing. Vestibular neuritis usually is an acute presentation, whereas in BPPV is intermittent decay. So in vestibular neuritis is acute, spontaneously triggered, not by provocative, and can last more than 24 hours. Whereas in BPPV, less than a minute. And in vestibular neuritis, basically the clinical importance is it's an acute vertigo for the first time. You have to rule out posterior circulation stroke. Whereas in BPPV, usually triggered by position and lasts for seconds. So it can be recurrent if not treated.
Okay, so coming back to what you talked about stroke, of course that makes everybody sit down. How? I mean, of course, when a patient comes to you, giddy, you worry about, is this a stroke? That's why, you send to a neurologist. Is there anything in the history which will make you, of course, if the patient has neurological signs, well and good, but when would you decide that this may not be just BPPV, it could be actually a stroke?
Okay, BPPV normally is triggered, whereas in stroke, a posterior circulation stroke or acute vestibular neuritis, they mimic the same thing. It's an acute presentation, severe vertigo, nausea, vomiting. If it is a central pathology, it's a stroke. Patient can't even walk. If somebody carries the patient, then you have to think of the patient might have a posterior circulation stroke. And then you look at the eye. In vestibular neuritis, the nystagmus is unilateral. Whereas it is a central pathology, it's gaze evoked. You ask them to look at the right side, the nystagmus beat to the right. You ask them to look at the left side, they beat left. Sometimes they have vertical nystagmus. So look at the nystagmus and then also look at the head impulse test. There's a test called head impulse test. You do a rapid head movement to ask the patient to look at your eyes. Okay, see whether the patient can fix the eyes on the examiner's nose. If they can't fix it on the nose, that means this is a peripheral cause. It's a good sign. So when the head moves, the eye does not move together because of the semicircular canal plays a role in the movement of the eye. So then it's a peripheral cause.
Okay.
And would one important differentiating point be the persistence of the symptoms? Like a stroke means things don't go away, whereas in these conditions, only certain movements trigger.
No, in vestibular neuritis and stroke similar. That's why you have to do the test called Keen's test. HI, head impulse test, test of skew deviation and nystagmus. So this is 3 tests we need to check. If the nystagmus is not unilateral, that's the central pathology. If the head impulse is normal, that's a central pathology. Then there is a test of skew deviation. So what you do is you close the eye, cover, uncover. You close this eye and then you move to see the eye whether it's in the right position, it's in the same position. If the eye moves up and down, this is a central pathology. This is called test of skew deviation. So this normally we try to train all the ERMOs to look for this Keen's test.
So your advice to GPs, suppose a GP comes and patient feeling giddy, goes and sees the GP. What sort of advice would you give the GP to say, hey, just give some Stamotil, IM Stamotil and chase the patient away, or I think this patient should go to the hospital?
Okay, so basically if the patient can walk into the clinic, most likely vestibular neuritis. First episode, severe vertigo with nausea and vomiting. If the patient walks in, very unlikely to be stroke. Secondly, we will train the GPs how to examine the eye. Basically, looking for nystagmus. If it's gaze evoked nystagmus, beating to the left, beating up and down, please refer to the neurologist. Straight away, pack the patient and sent to the hospital. Third is GPs can train to, they can do a head impulse test. They can Google and check what is a head impulse test. Okay. And then if the head impulse is normal, this is a central pathology. And then test of skew deviation. You ask the cover and uncover, see the patient's eye is in the same position. If the eye move up and down, this is a central pathology. So there are 3 clinical examination they can do. And you don't have to be a neurologist to do this.
Okay, yeah, good. So there are how many variants of BPPV?
Right. Thank you. So as you know, there are 3 sets of semicircular canals, meaning the right and left, posterior, anterior, as well as the lateral semicircular canals. And Dr. Puri also mentioned earlier, there are 2 types of BPPV, canal ichthysis as well as pupil ichthysis, depending on the position of the otoconia in the semicircular canal, whether it's in the ampulla or is it in the canal itself. So just for your information, okay, there are about 22 known variants of unilateral BPPV. Okay, you can see the list below. We're not going to go through, but just as a simplified version of things, okay, we can just break it down into the posterior, lateral, as well as the anterior semicircular canals. And for each, so as I mentioned earlier, as you do the Dick sulfide as well as the macular pagnating maneuver and identify nystagmus in a specific type of position, you can then correspond, is it a posterior, lateral, or anterior canal? And you can do the respective maneuvers that are listed down here below. Okay, there are about 30 different CRMs, canalate repositioning maneuvers. But to simplify things, these are the ones that we have selected. It's the Sermont maneuver to treat any type of posterior canal, modified Zuma maneuver to treat any type of lateral canal, and Jacobino maneuver to treat any type of anterior canal is sufficient because, number one, these maneuvers do not have too much emphasis on the angulation of the head, and the patients can also bring it back, use these maneuvers and go back home and perform it at home as well. So it's not too difficult to perform these maneuvers at home. And again, it's very important to advise the patient to conduct the CRMs for 3 repetitions twice a day for 5 days, and if possible, review the patient on the 6th day, okay, to see whether or not the patient still has symptoms less nystagmus, and on the off chance that patient still has symptoms of BPPV, again in the same type of nystagmus from before, it will be good to continue 1 more cycle if the symptoms are persisting, right?
So why is BPV so common?
So the predisposing condition for BPPV, basically aging. After a vestibular neuritis or labyrinthitis, as I mentioned earlier, Meniere's disease, head trauma, vestibular migraine. Sometimes prolonged bed rest also can cause this, or after a surgery, like a drilling, mastoid surgery, neurosurgical procedure, so you drill the temporal bone, so that can also cause the particles can get dislodged after surgery, or sometimes there's no cause, idiopathic.
Once you've dislodged it and okay, like you do all your maneuvers and goes back into your ventricle, can it recur?
Yes, definitely can recur. But once the patient knows this is BPPV, in future they know, oh, when I move only I get it. But the first time they really panic, I don't know what the hell is happening to me. So all of our patients, we train them this will recur. So we tell the patient, look, the last time you had the right posterior canal BPPV, you do the same exercise. Normally, what I do is I teach the patient and give them the video. So in future, it happens, it's possible, the same site, you do the maneuver first at home. If it recovers, it's good. If it doesn't recover, that means it's in the wrong canal. So please come, then we will reassess the patient.
So yeah, what's the gold standard? How do you diagnose it?
All right. So the gold standard is obviously by using a video nystagmography device because it allows for visualization of the nystagmus, both in video as well as graphical format for you to correspond both of these with each other. But alternatively, right, which is most cases where VNG is unavailable, the practitioners can either use video Frenzel if it's available, Frenzel goggles, which you can see here in the photo on the bottom right, or M glasses, which is basically like a magnifying glass and also it removes fixation of the eyes, so that allows the patient's nystagmus to be more visible. Okay, And sometimes, even in certain cases, you can even use your handphone, right? Just you have to have somebody to help you. And when you bring the patient down into the Dix Hall pipe or the provocative maneuvers, Dix Hall pipe or macrophageal maneuver, you get your assistant to record the eye movements and to see, observe, because with the handphone recording, you can play it back, to see if there's any nystagmus and make sure that you keep the eyes open. And finally, obviously, if all equipments are unavailable, direct vision can also be used. But make sure you inform the patient, right, that when we do the maneuver, you feel some dizziness, some symptoms, and to keep the eyes open, right? I always tell my patients the answer is in your eyes. So you keep the eyes open so they can observe and help diagnose whether or not you have BPPV, and subsequently diagnose where the crystal or the particle is within your semicircular canal.
So sometimes, especially in patients with lateral canal BPPV, they are more prone to get vomiting. So sometimes when you put them in the position they vomit, they close the eyes so you miss it. So that's why it's very important for you to, for example, tell the patient, please open the eyes even and try to capture. Then you got time to replay and see where is. So sometimes it's a bit difficult. It's very common. So if you don't have recording, sometimes very difficult. You don't know which, because the answer is in the eye.
Right. So just following on, to diagnose BPPV, as Dr. Puraviappan mentioned as well, the answer is always in the eyes. So I just have a series of videos here for us to see on how can we diagnose BPPV. So the key is to study the nystagmus, and again, the fast pace is the direction of the nystagmus. So in this case, the first video that we see here, patient has a right torsional upbeating nystagmus, and when it is upbeating, that is indicative of a posterior canal involvement. Right torsional indicates that it's a right-sided involvement. So by seeing a right torsional upbeating, we understand that it is a right posterior canal BPPV. The second video here, what we see is actually a left torsional downbeating nystagmus. Downbeating is indicative of an anterior canal involvement, whereas left torsional is indicative of a left-sided involvement. So by looking at a left torsional downbeating nystagmus, we can identify immediately the patient has a left anterior canal BPPV. And last but not least, the third video here, if you look at it, you can see the patient has a left horizontal beating geotropic nystagmus. Horizontal beating is indicative of a lateral canal involvement. And finally, a left geotropic is indicative of a left-sided involvement, and it is particularly a canal lithiasis type BPPV.
This is a bit too much for
No,
us.
very simple. Okay.
We will pass to the ENT.
No. Basically, if the canal is like this, lateral canal like that, so the eye will move laterally. The segments will move laterally. If it is a vertical canal, either anterior canal or posterior canal, they have to move up and down. That's all. The movement of the fluid is the eye movement. Very simple. So if it is a posterior canal, it's upbeating. Just remember that. If it is a horizontal movement, it's a lateral canal. If it is a downbeating, it's opposite, anterior canal.
So the purpose of localization is to enable what type of maneuver to move the
Yes,
particle.
exactly. We don't want to know which side or what kind of maneuver.
To just pass it to you guys.
Yeah, that's it.
No, actually, this one the GPs can manage. It's not very difficult. Simple. In US, mostly is managed by the physical therapists.
Oh yeah, I was told one patient was sent to the physio for vestibular physiotherapy. So I guess this is what it is.
Yes.
Vestibular physiotherapy.
So we got vestibular rehabilitation therapy, and within vestibular rehabilitation therapy, we do canal fluid position maneuvers, which are the maneuvers that we've discussed all along.
So is there any medication? Everybody gives beta-cert or Stemetil. So boleh tak?
No, BPPV is a mechanical disorder requiring mechanical treatment. There is no medication required for BPPV.
So then the fellow patients will swear by beta-cert and swear by Stemetil.
And if you look at the pathophysiology, then you understand that basically it's the particles from the utricle get dislodged, enter into the semicircular canal. It's a foreign body in the semicircular canal. You have to, if there's a foreign body, you have to remove it. So you have, in this case, you have to do particle repositioning back into the utricle.
So they will not respond to beta-cert, cenerazine, all this?
No, not at all. So what happens if you, one day the particle will go back to the original position? We don't know. It can take weeks, sometimes even months. Without seeing doctors also, sometimes spontaneously it can enter into the utricle. But to reach that process, sometimes patient get history of fall, and then some get even a condition, they get very anxious, they get like psychogenic dizziness, which we'll talk to you later.
Is there any role for any form of surgery to remove the particle?
No, there's no role of surgery.
So what are the common causes of vertigo besides BPV?
So,
other causes?
Vertigo is basically a symptom. So there are more than 40 differential diagnoses of balance disorder. However, the more commoner ones of causes of vertigo in ENT clinic setting, basically vestibular neuritis, VPPV, labyrinthitis, vestibular migraine, Meniere's. These are the more common, but there are many other causes of vestibular disorders.
So maybe you can answer this question there, because
Okay, why dizziness is sometimes exacerbated by complex visual environment? This is basically sometimes known as the supermarket syndrome. Supermarket syndrome. When the patient goes to supermarket, they feel dizzy. I have a patient said every time the wife asks him to go to Speed Mart to buy things, the moment he walk in, he feel dizzy. So he rush for. Okay, so basically this is due to abnormal optic flow. So the right optic and the left optic flow does not match. So the patient feel dizzy. And in visual vertigo can occur in complex and busy situations such as supermarket, train station, reflective floor. Sometimes when they scroll the phone, they feel dizzy. And sometimes mosaic pattern, they see the floor, they feel dizzy. So these are the, and I just show you some animation.
coming back to that thing, looking at the floor dizzy, that one you cannot control, cannot correct by doing that maneuver.
No, that is nothing to do. That is a form of vestibular migraine. You can see patient get confused. Like our lecturers give us too much information. Sometimes we also get confused. Like currently, too much information. Sometimes they feel.
So the cat also getting confused.
Yes.
I feel like a cat right now.
So this here, you can see this video here. This is another form of condition called oscillopsia. This is classical of bilateral vestibulopathy. That means the patient's both vestibular system is affected, or it can be a feature of cerebellar stroke. Can present like this. That means they feel that the whole world is going up and down. This is called, and in vestibular migraine, sometimes they can have scotoma or scintillating scotoma. They can see black spot. This is what you can see on this video. So this also you need to ask. So sometimes patients in BPPV will have vestibular migraine. So you, by just treating the BPPV, might not treat the whole dizziness. If
How
they
do you
have,
treat vestibular migraine?
that is another, you have to look for the, basically medication wise, there are many medicines, so we can refer to the neurologist, or they can treat with flunarizine, calcium channel blocker, flunarizine, or sometimes you can use a magnesium supplement. We can start with magnesium supplement for vestibular migraine. Many patients vestibular migraine do well with magnesium. We have one lecture on that, on vestibular migraine.
What if it's untreated?
So if you don't treat, there's an increased risk of fall and fractures. Unnecessary treatment with medication, additional investigation. If you don't treat, the patient will go into MRI. Will refer to other orthopedic surgeon. They think it's a neck problem. And if you're on medication, cost them a poor compensation. So in patients with BPPV, you should not give medicine because otherwise they get poor compensation because of long-term medication. And without performing a canal repositioning maneuver, patient with BPP might even take few weeks to months to recover. And if you don't treat, sometimes they get persistent postural perceptual dizziness. This is the psychogenic dizziness I mentioned earlier. You can see here, the patient feel persistent because the patient feel dizzy most of the days, at least for 3 months. To make a diagnosis, they feel dizzy. And it's postural. When the moment they get up, upright position, they feel dizzy. And perceptual, really they feel dizzy, the surrounding feeling off balance, they feel swaying, rocking sensation. And basically this due to communication breakdown within the system. Although there is nothing physically wrong, you do all the investigation, everything is normal, but the individual physically wrong with the individual, but they no longer able to sync. The brain cannot sync with the semicircular canal and stuff like this. And as a result of this, they feel unsteady on the feet. They feel brain fog, and they can, some of them associated with anxiety and depression. So for this patient, we need to do vestibular rehab therapy or cognitive behavioral therapy. And sometimes we can give SSRI and SNRI for these patients. It's a
I see a
psychogenic.
lot of patients like this. They say psycho.
So actually this condition is called, if they have more than 3 months feeling dizzy all the time, then the diagnosis is persistent postural perceptual dizziness.
I think I asked you this question earlier and you said you will answer
So,
no.
MRI is done basically when you see when the patient has a neurological sign, okay, such as diplopia, dysarthria, or ataxic gait, or they have cranial palsy. Otherwise, they can have persistent vertigo not responding to treatment. Then you might need to do an MRI, or suspected central cause, such as in multiple sclerosis, brainstem lesions. You suspect cerebral stroke.
Or acoustic neuroma. I mean, that's a common thing that people keep on saying.
Okay, acoustic neuroma, basically the patient will present with tinnitus, unilateral tinnitus with hearing loss. Okay, so when the patient has unilateral hearing tinnitus with the audiogram shows hearing loss, you have to think of acoustic neuroma. Acoustic neuroma is the growth of the vestibular nerve. So the vestibular nerve and the cochlear nerve are in the CP angle area, in the internal auditory meatus. So when the vestibular nerve grows, it compresses on the cochlea. So the first symptom they will have is tinnitus. Okay. I want to ask you, Dr. Kannan, in this chair, who do you think is the dizzy patient? 1, 2,
Number 3.
number 3. What about you, Dr. Evan?
Yeah, number 3 maybe. Turn his head. Yeah.
I won't ask you because she knows the answer. The dizzy patient is actually the ball.
The ball.
Yeah. A dizzy patient embarks on an epic medical hunt, visits a GP, referred to a cardiologist, and cardiologist says heart is not the method. Next stop is the neurologist, who squints at the brain and declares no central conspiracy. Here. Then the orthopedic for some, then they refer them to orthopedic surgeon for neck didactic work, as it is the cervical spine has the secret code. And the patient at last gives up and go and see a CINC.
You forgot number 6. Hematologist, you're not anemic. Go away.
Sometimes they also refer to the hematologist. Okay. So at last the patient ends up with the sensei as a mystical healer. Patient is kicked around like a ball. The take-home message is vertigo is not a diagnosis. Consider BPPV in elderly patient with positional dizziness. It's at least 30% in patient with recurrent dizziness. Sometimes coexisting migraine may occur together. Please do the provocative maneuver, the stress test on the, such as Dix-Hallpike test and maculopectomy, and look at the eye. And no medication is needed for BPPV. Only canal repositioning maneuver. Thank you.
Thank you. Thank you
Thank
very
you.
much.
We learned a lot.
Yes,
Learned
I
something
have
completely
learned
new.
quite a lot. I only heard about vertigo when I was a medical student, but now it's good. I've learned a lot. Thank you very much, Khuhan, and thank you very much, Puravi.
Okay.
Pass it back to you, Alan.
Yeah. So we got about 5 minutes for Q&A. So if we can go to the Q&A here, and now all these questions about asking for how to get points, all that we'll skip. Yeah. So that's a bit later. So question for Dr. Puravi: what are the 3 clinical exams that can be done in the GP that you mentioned? Dix-Hallpike, nystagmus, test of skew.
Okay. So basically, depends on the presentation of the patient. If somebody comes with acute vertigo, then you don't do a Dix-Hallpike test. Dix-Hallpike test and maculopectiny, if you suspect the patient has DPPD, you want to know which canal is in. Dix-Hallpike test is for anterior and posterior canal. Maculopectiny is for lateral canal. So if recurrent vertigo due to provocative, then you do a Dix-Hallpike and maculopectiny. If somebody comes with acute vertigo, then you have to do the 3 tests. The HINS test. Head impulse, test of skew deviation, and look at the nystagmus. Head impulse, maybe I can, Dr. Jaya, maybe you have a next session, we will talk on this, part 2. Okay? Nystagmus, if it is unidirectional nystagmus, they follow the Alexander's law. That means it's a peripheral problem. You're safe. You can treat the patient. If the patient has gaze-evoked nystagmus, that means to the right, it beats to the right. When you look at the left, beating to the left. Or if any vertical, especially if it's downbeat, then you have to think as central, pack the patient and send to the neurologist. Test of skew deviation, you close the cover, uncover. Look at the eye. If the eye is in the right position, no problem. Every time you cover and uncover and the eye moves up and down, this is a central pathology. This is called test of skew deviation.
I like the one you say, if you can walk into the clinic, it's likely okay. If you cannot walk,
yes.
pack the patient. It's a
Yeah,
lot
this is
easier
something that
than looking for cerebellar signs. Feature. If you can't walk, pack him to the hospital. Yeah. Okay, basically, if there is no nystagmus, it may be a benign condition. If nystagmus, better to refer. Is that right?
No, it's not right. Basically, if there is no nystagmus, there's another condition called subjective BPP. Okay, where the patient might not have any nystagmus, but the patient has symptomatic. That's one. 2 is sometimes patient have nystagmus. It may be not necessarily BPPV. They don't have symptoms. It can be vestibular migraine. Okay. If you have nystagmus, so it depends on the situation. If the patient comes to you and say, "Doctor, I feel dizzy when I lie down," you can treat it. You have to look for the nystagmus. Not if you have nystagmus, you don't refer. You can actually treat it. Look at which side is the nystagmus. Whether it's a vertical, whether it's going upwards, it's the posterior canal. If it's going downwards, it's the anterior canal. If it is lateral, horizontal is a lateral canal. So actually you don't have to refer. Because this is a patient is a complaint. Every time I turn to my right, I feel dizzy. But in patient with acute vertigo, they come with, you examine at nystagmus. If it is the upbeating nystagmus, you're not doing any Dix-Hallpike maneuver. Just spontaneously, they're doing upbeat nystagmus or downbeat nystagmus or gaze-evoked nystagmus. Please refer.
Which drug is better to treat? I think we covered this. So
Definitely not.
no
drug.
drug works.
No drug.
Yeah. Okay. Can sudden movement of the head, e.g., jumping out of the bed, cause giddiness or sudden change in posture?
Basically, if the patient has BPPV, yes, when you jump out of the bed, can cause dizziness. If the patient has BPPV, change in posture will get. Normal person should not get unless Dr. Kannan, you can explain, a patient with postural hypotension.
Yes.
Can they, when they jump out from the bed?
Yes, of course.
Okay.
The blood pressure drops, yeah.
Can bidirectional nystagmus occur in BPPV during the Dix-Hallpike test? Or does it mean it's a central cause?
No, if in a BPPV you're having a
Bidirectional.
basically if you're bidirectional, patient must have symptoms unless patient have more than one canal involvement. Then care.
Yes. Okay. Okay, I think the other question is the same. That was the latest question. I think we've covered. Anyway, we're running out of time. So thank you all for your questions. And we're all feeling giddy now. So we better go to the
Thank you.
points section. Don't forget to subscribe. But for those of you who have stayed on right to the end, and this is the moment you've been waiting for, and this is how to claim CPD points. This QR code will take you to the CPD application form. Yeah, it's just a code. If you scan with your QR code scanner, and then you fill up the form, and then submit it, and then the SGMC team will upload to the MMA to claim the point. We do not scan using the MMA app, please. Yeah. All right. So if you're watching this video late, you can still scroll the video until this part, and you can get the link to the office form and then apply. Let's see if anybody of you can have succeeded. You please let us know in the YouTube channel. But otherwise, it's been a very illuminating, informative. Yeah, because we just say reflexly giddy, give a better send off. So I think it's a lesson to learn for us to learn. Yeah. What is the are there cases of BPPV not due to particle cause?
Yes, that's central positional vertigo. It's a central cause.
Right.
So in that, patient might not have symptoms, but they have signs, just nystagmus. Can last for 10 minutes.
But BPV specifically is relating with the particles in the semicircular canal. Without it, then we do not call it BPV.
That's what I mean. If it's BPV, it must be due to a particle cause. Yeah.
Particles are not in the utricle and somewhere in the semicircular canal.
Okay. So thank you, everyone. We shall end the stream quite soon. If you have problems getting the point, you can post as a comment to this video, or else contact the SGMC GP liaison, and she'll help you. And otherwise, I'd like to thank all the panel today for illuminating session and all your questions for all you participants, and we hope to see you again in the next one. All right. Thank you and have a good weekend. Yeah.
Thank you.
Bye-bye.
Learned a lot.